Well, thank you very much. I am delighted to be here virtually and be talking about my favorite topics, menstruation, bleeding disorders. And I hope that you take away something from this talk that's useful for your everyday practice. And I'm a fan of the Bloom taxonomy for teaching. So by the end of this presentation, you should be able to recognize defining features of heavy menstrual bleeding, explain the relationship between heavy menstrual bleeding and bleeding disorders, and compare and contrast treatment options for heavy menstrual bleeding in patients with bleeding disorders. So I always prefer a case-based format, and this is a very typical case that shows up in my clinic. I do have a specialized clinic where we see folks, myself and a gynecologist, specifically for heavy periods, but most of them come to us exactly like this. So a 18 to 50-year-old woman coming in with a microcytic anemia. We presume it's probably going to be iron deficiency, but an otherwise normal CBC. And so I just kind of want you to like take a minute and think about like what is the differential that's automatically running through your head here. Um, Obviously, we get a little more history in this particular patient. And most of my patients, they've been anemic a long time since their teenage years. And then they say their periods. When you ask them about their periods, they're like, "Oh, my periods are normal." And so this is the one quote I want all of my trainees to leave my clinic with. Always believe women unless they say their periods are normal, and then ask more questions, because you would be amazed how many people have horrific periods, and they just think it's normal because we don't talk about it. And so today I'm hoping to really give you the tools to talk about it in a really specific way to get those answers. So first of all, let's distinguish between normal and abnormal, because I don't know about you, but I did not really get normal menstruation taught to me in med school. I kind of had to learn it myself and from my gynecology colleagues. So just to put this in perspective, so the average age of menarche in the US, somewhere between 12 and 13. Average age of menopause, 51.4. Average cycle length, I think we all know, is 28 days, but that can vary from as few as 21, as many as 35. The more important thing is that it's relatively regular, meaning it only varies by, you know, maybe 3 to 5 days per cycle. Average duration of menses should be 2 to 7 days. Median blood loss, and we actually know this, and I'll give you a little scoop on how we know this, is 30 to 50 milliliters per cycle. The definition of heavy menstrual bleeding historically has been greater than 80 milliliters of blood loss per cycle. And so the reason we know this average is because some very enterprising folks in the UK did a study where you can actually collect menstrual products and put them in this thing called a stomacher blender, and you can actually do spectrophotometric measurement of the hemoglobin that's lost. So they have a pretty good idea of the actual volume of blood that's lost. And so they got a bunch of women to fill out these surveys about how often they changed their products. And then a huge subset of them actually brought in their menstrual products. So they were able to get these accurate measurements. So 226 total did the menstrual collection of the 782 who completed the questionnaires. They found that 34% of these folks met criteria for heavy menstrual bleeding by having losses greater than 80 milliliters per cycle. And hopefully you can see my mouse here, but this red line demonstrates that cutoff, that 80 milliliter cutoff. So all of these folks above that line had heavy periods. And you can see up here, one person lost like half a liter or more, which is pretty extreme, but women can lose a lot of blood in their menses and not realize it, especially when they go on for a long time. So like I said, they matched the clinical features with these measurements, and they took away a few important things. So first of all, they reported which clinical features were consistent with greater than 80 milliliters of blood loss per cycle, which is, again, the definition of heavy menstrual bleeding. And then they also just looked at factors associated with folks who had more bleeding than average. And so the features associated with blood loss greater than 80 milliliters per cycle were changing of protection more often than hourly. And I want to point out that this study was done in the 90s, and menstrual technology has progressed a lot. So a lot of us now actually say more often than every 2 hours. Low ferritin, or passing clots greater than 1.1 inch. With increased blood loss, they found actually patient reports saying they have very heavy bleeding as opposed to heavy or moderate bleeding was significantly predictive of increased blood loss. So we can believe women when they say their periods are heavy, which is why I say only don't believe them if they say their periods are normal. um, Getting up to change protection overnight, and the total number of products used per cycle, but that's not really a helpful clinical metric because people use all different kinds of products, which I'll get into in a few slides. The newest definition, which is the important one to keep in mind when you're deciding whether or not to treat somebody for heavy menstrual bleeding, is a much more subjective quality of life based one. So, excessive menstrual blood loss that interferes with a person's physical, social, emotional, or material quality of life. Although I will say, even this one, I sometimes have patients come in and they have to stay home a couple of days every month for their period, and they're changing their menstrual cup every 45 minutes. And I ask them if it interferes with their quality of life. And they're like, no, it's always been that way. So even this one can get a little bit tricky. So when I'm seeing somebody in clinic as a hematologist, it's quite important for me to know whether or not they're truly having excessive losses, just so I can decide whether or not to go down the route of should I evaluate this person for a bleeding disorder, not necessarily because that would dictate whether or not we treat them, because again, that's based on quality of life. But if you have time for just 3 questions in your clinic, I would ask, how often do you change protection? And so any more than every 2 hours is abnormal. And also make sure you're asking if they're wearing double protection. I see tons of women, they wear a tampon and a pad, a cup and a pad and period underwear. They wear multiple pads at once. So you got to ask about that. Ask them if they pass clots greater than an inch in diameter, and ask them if they've ever been diagnosed with iron deficiency. And of course, in our clinics, we can go ahead and check ferritin levels. There is a sort of more patient-facing friendly metric that's been used by a variety of organizations who advocate for women's health. This one is from, I think it's the European Hemophilia Consortium. They have these great little icons. So they say they encourage women to seek care if their periods are lasting 7 days or more, which is a marker of abnormality. They need to change menstrual protection again more often than every 2 hours. And if they're passing clots larger than, here it's a €1 because this is from Europe, but we can also say quarter or inch. Because I've had a few Gen Z patients who don't know how big a quarter is. So you have a backup. Um, and so I put this warning slide in here, slightly tongue in cheek, but I'm going to show you some slides that I've been told make some people uncomfortable. And because these people are hematologists and are very comfortable with blood, I can only assume that they were made uncomfortable by the period products that you're about to see. And so if that makes you feel uncomfortable, you are not alone. But I also want to invite you into kind of a different mentality, thinking about we feel very comfortable asking our patients in detail about their bowel movements and all kinds of other sort of personal information. And periods really are no different. And I think it's really important for us as clinicians to come to the patient looking and feeling comfortable and normalizing this conversation. Because if we're nervous about it, can you only imagine how the patient feels? So I just want to kind of invite you to, notice if you're feeling uncomfortable about it and maybe do some thinking about why, and practice talking and thinking about these things so you feel a little bit more comfortable. So the next couple of slides, I want to talk about what we've kind of called alternative period products. And so the metrics that I just spent a bunch of slides showing you from the Menorrhagia 1 study, those are all from pads and tampons from the 90s. Now we have a ton more options. We have menstrual cups, menstrual discs, and period underwear. And they have very different absorptive capacity. So we can't think about them in the same way as we think about changing a pad or tampon. And here is the uncomfortable slide. So as Dr. Salas mentioned, we did do this study. We did test the absorption of, or the containment capacity of these various products. So we can bring that information to conversations with our patients so we can more accurately understand their blood loss. And the reason I pick this particular photo is that nobody ever believes us that period underwear didn't absorb any blood. And to be honest, there might be other period underwear companies that absorb more, but this is kind of what it looked like, right? We poured blood on products until it didn't absorb anymore. So that's where this data that I'm about to show you comes from. So here is, we did a variety of different pads, tampons, different sizes of the same underwear. We did menstrual discs and menstrual cups. And I just, the reason I kind of showed you that slide of menstrual discs and cups is you can kind of see, so they don't absorb anything, they just hold things. And we held things where like the top of it was parallel to the ground. In a human body, those are going to be tipped. So these might not be exactly the same in a human body as what you see here. But what we saw, right, is pads can absorb on average. So these are averages with our range here. So they can absorb up to 40 milliliters of blood. Tampons approaching 30, underwear very little. Menstrual discs, some of them hold 70 milliliters of blood, and menstrual cups, a lot of them hold like up to 30 milliliters of blood. So if you put that in perspective with what I told you earlier about 80 milliliters being too much, you can quickly see how soaking a couple of overnight pads or filling a menstrual cup 3 times in an entire cycle put somebody in that heavy menstrual bleeding category. So that's why it's so important to really think about what products they're using, how they're using them, and kind of try to gauge the blood loss that way. So with that data, I have modified my questions to include not just how often do you change your protection, but what kind of protection do you use, and do you use it in combination? Really have applied that research that we did in kind of our wet lab to my conversations with patients. And when I start to say things like, well, if you fill that period cup, that menstrual cup 3 times per cycle, you're having heavy periods, they're just kind of flabbergasted. And in my clinical experience, I will say a lot of folks who come to me have gone towards that menstrual cup direction. And I can tell you, like, a lot of teachers that I see, physicians that I see, they go for the cup because they're like, I don't have time to run to the bathroom every 2 hours. So instead of going and getting checked out and getting treated, they think, oh, this is just normal. And they use the cup and they figure out how to keep going in their daily lives. So that is an important aspect of taking history in these folks. So off of that soapbox and back to the patient presentation. So if you get a little bit more detail, again, this is very common in my clinic. She's filling a menstrual cup every 3 to 4 hours, which could be 90, 120 milliliters lost per day. And we always ask patients to tell us about the heaviest day of their cycle. So it doesn't have to be every day that they're filling it this much, but if they fill it this much on their heaviest day, that's worrisome. Commonly passes clots greater than 1 inch, and the average ferritin in my clinic is about 6 or 7. So very typical patient in my clinic. And again, a lot of these women are in their 40s or even 50s, and they've gone their whole lives with this and just hasn't been noticed. So I want to transition a little bit to talking about heavy menstrual bleeding and bleeding disorders. And it's not really a chicken and egg situation because inherited bleeding disorder was obviously there first. But the way that women come into care can be different, right? Sometimes I get folks, I love this. Their mom has von Willebrand disease. They get checked out as a kid. They come to me when they're 18, transitioning from their pediatric hematologist, and their periods are well managed, and we just keep on keeping on. That's great. But more often, what I see is somebody coming in again with decades of heavy menstrual bleeding, and that's how we make it to the disorder of bleeding, the diagnosis of bleeding disorder. But it's helpful to keep in mind that patients can come in both ways. And just to kind of put this in perspective, so for patients with bleeding disorders, the vast majority are going to have heavy menstrual bleeding. We're talking like 80+% are going to have heavy menstrual bleeding. So we can expect that. Of patients with heavy menstrual bleeding, a minority will have a bleeding disorder. It's somewhere between 10 and 20%, depending on the data you look at. So I'm going to spend a lot of time in the next slides encouraging you to think about bleeding disorders in these women. But I also want to like walk a fine line. Like, I don't tell every patient who comes into me like, oh, you could have a bleeding disorder, and scare them. So just to kind of put some perspective on things. Um, how do we address these patients that are coming in with heavy menstrual bleeding, and we're thinking about, okay, what next in terms of evaluation, right? The first thing you want to do is make sure you're taking a bleeding history, asking about, do you have epistaxis, do you bruise easily, all of these things. And because I know we all have very limited times in our clinics, a lot of times I will send patients to this website called letstalkperiod.ca. It's an excellent website. It's run by a physician friend of mine. And they actually have a self-bleeding assessment tool that a patient can click on. It's in English and in French because she's from Canada. Hopefully someday they'll have it in other languages as well. But they can actually go through this and they can come back with a score that can tell you whether or not to be worried about their global bleeding. And in women, that score is generally anything higher than 5. So we talk about family history. Does anybody else in your family have heavy periods? Does anybody else in your family have a bleeding disorder? Always make sure you're getting a ferritin and a CBC in these folks because there's definitely many patients who are iron deficient, even if they're not necessarily showing it with anemia. And I think particularly in this young, very resilient population, their bodies will compensate. They won't be anemic, but they can still be symptomatic from their iron deficiency. And I also think about a gynecology referral. And I'm going to talk a lot in the next few slides about kind of what the different treatment options are, but some of the best treatment options can really only be implemented by a gynecologist. So I can temporize folks until they get to a gynecologist, but definitely be thinking about that. And anybody who has heavy periods, they may also need other kinds of evaluation, like an endometrial biopsy or something else. So make sure you're involving gynecology colleagues. And I understand that we may have a few of them listening today, which is wonderful. If you are here, thank you for the work that you do. So when deciding, I take all this information in and then I'm trying to decide, like, do I work this patient up for a bleeding disorder? And I like to think about have patients with just heavy menstrual bleeding. Then I focus with what I call heavy menstrual bleeding plus, which comes down to symptoms other than heavy menstrual bleeding, right? And this is a lovely little diagram of the different categories of bleeding that are included on a bleeding assessment tool. Things as extreme as intracranial bleeding, which obviously is very rare, and easy bruising, which is obviously very common. So anybody who has like postpartum hemorrhage, maybe, or bleeding after surgery. They had to go back after they had their wisdom teeth removed. Those are folks that I really kind of think, oh, maybe this person has a bleeding disorder. I should work them up. Easy bruising is always tricky because iron deficiency can actually cause easy bruising. I would say I probably lean towards working up folks more often than not because I think there's more danger in underdiagnosing folks. But that's a little tricky. I have plenty of patients in my clinic who have had heavy periods, they have easy bruising, but they had their tonsils out and it was fine, and they had a gallbladder surgery and it was fine, and those folks don't have bleeding disorders. So bruising is a little tricky. Also, anybody with a family history of an inherited bleeding disorder and heavy menstrual bleeding, obviously I'm going to be working that patient up for whatever they have a family history of. So what do I think of, what tests do we send when we work these folks up? And I'm really kind of specifying here what I think is appropriate for like a general physician to do, internal medicine physician, family practice, gynecology. Like you don't have to be a hematologist to send these tests. PT, PTT, and fibrinogen, very basic first line. And then I send a von Willebrand panel. I will say von Willebrand testing has become increasingly tricky. There's data to suggest that levels from reference labs, meaning labs where the blood is drawn and and processed in the same location, are more accurate than, for example, somebody out in rural parts of the state. They get their blood drawn at like Quest or whatever, and then it's shipped usually to ARUP in Utah or something like that. So we always try to get them on site at OHSU whenever we can. If you have a patient, it's not going to be wrong to send von Willebrand testing, but just to let you know, it's best if you can send it. I'm sure Stanford has its own reference lab that processes these. So that's best if you can do it. Um, And then consider a hematology referral for the non-hematologists in the room. Like if you're concerned, it's never wrong to send somebody to hematology to get checked out. Again, I think we underdiagnose way more than we overdiagnose. Some things to keep in mind is that heavy menstrual bleeding is very common. 1 in 3 women will have it. So I guarantee you there are patients on your panel, unless you only see men or people over 60, there are patients on your panel who have heavy menstrual bleeding. And the 80 to 90% of them will not have a bleeding disorder. So even though I'm talking a lot about bleeding disorders because I want to make sure that we don't miss them, realistically, most of your patients will not have these bleeding disorders. So I try not to scare them too much. But again, back to the concept that we're underdiagnosing. So again, this is another lovely infographic from EHC. They say 1 in 10 women have with heavy periods have a bleeding disorder, somewhere between 1 in 10 and 1 in 20, but only 2% of them wind up getting tested for bleeding disorders. So we are still under testing. So yeah, this is I think a lovely little infographic that reminds us that we do need to be thinking about this. So moving on to conversations about inherited bleeding disorders. So inherited bleeding disorders are rare by definition, but I want to focus on 3 today that might surprise you a little bit. So probably nobody's going to be surprised by von Willebrand disease. That's the most common bleeding disorder worldwide, affects 1% of the population. None of these 3 disorders, by the way, have any increased incidence in people from any specific parts of the world or anything like that. The mutations can kind of happen to anybody, although certainly we hear a lot about von Willebrand disease. In Northern Europe, that's where it was kind of first discovered. But hemophilia A and B happen all over the world. And you might be surprised that I put hemophilia A and B here and they have stars next to them because you may think, hey, it's an X-linked disease, only men get it. Not true. And certainly not only men are symptomatic. So I'm going to talk a lot about that in the next few slides. But I want to start first just by briefly covering von Willebrand disease. So von Willebrand factor is a magical little factor. It does a lot of things. It helps tether the platelets to the collagen when there's an injury to the blood vessel. It helps aggregate the platelets. And it also, if you recall the term chaperone protein from med school, it keeps factor 8 safe in the circulation. So there's a variety of ways that this can go wrong. Folks most commonly present with mucocutaneous bleeding, and that includes heavy menstrual bleeding, but also epistaxis, also trauma-related bleeding, easy bruising. I ask folks, if you cut yourself in the kitchen, if you slip with a knife, does it stop within 10 minutes or last longer? A lot of my von Willebrand's patients say like, oh yeah, I have to wear a Band-Aid for 2 days. Not normal. So that's kind of how I think about von Willebrand disease presenting. And there are 3 different types, and I really encourage the non-hematologists not to get too stuck in the weeds here because there's a lot of nuance and it doesn't really make a huge difference because the treatment is generally the same. But for us as hematologists, we do need to know, and this I think just summarizes nicely kind of the 3 different ways things can go wrong. So type 1 is the most common type, just a reduction in overall supply of von Willebrand factor. It's a quantitative defect. There's still some, but there's not as much as there should be. It's less than 50% by definition. And there has to be bleeding symptoms. It can be between 30 and 50%. And if there's no bleeding symptoms, we now call that low von Willebrand. And now I'm getting into the weeds that I warned you about. So I'm going to move on to type 2. So type 2 is a qualitative defect. And we, I think, initially think of that meaning underfunction, which is correct. But it can also mean overfunction. So we'll see some patients with type 2 also have thrombocytopenia. There can also be defects in interactions. There can be platelet-specific von Willebrand disease, and also a type that actually presents just as low factor 8 because the function of von Willebrand factor as a chaperone protein is compromised. Type 3 is just like a total absence of von Willebrand factor. They're missing both of their genes for it. They make none. Very severe bleeding, present very early on. So as promised, carriers. So we have called, these people hemophilia carriers for a long time. I think it's important to keep in mind that when we think about the term carrier in other contexts, we generally mean somebody who has a gene for a disease, but is not symptomatic or is not presenting with that disease. And that's not technically true. So even though hemophilia is an X-linked disease, which means, a man only needs to have one abnormal factor 8 gene or factor 9 gene because he only gets one. Women, we have obviously two X chromosomes in every cell in our body. And if you remember the wonderful lecture from high school biology on the calico cat, and how the Barr bodies and different X chromosomes, one of the two X chromosomes is selected to be expressed in every cell in the body. And so roughly you would expect kind of half of those cells to express the wild type or the good, the effective factor 8, and half of them to express the ineffective factor 8. And that's generally true when it comes to levels. But it's important to keep in mind that patients can be symptomatic kind of regardless of their levels, and as hemophilia carriers. It's also important to keep in mind that every man who has hemophilia, all of his daughters will be hemophilia carriers. Every woman who has hemophilia, we often talk about like, oh, is there a male fetus? Is he going to be affected? 50% chance of having an affected boy, but also a 50% chance of having an affected girl. So the way it works out, there's actually more carriers in the world than boys with hemophilia. And so back to the question about symptomatology here. So this was a lovely paper that was put out several years ago where they documented rates of different kinds of bleeding symptoms. It was public. You can always tell when something was published in one of the British journals because they have all the extra A's added to hematomas and hemarthrosis. But they looked at everything from cutaneous bruising, post-surgical bleeding, heavy menstrual bleeding, GI bleeding, and they had 44 women who were hemophilia carriers, and 43, we try not to use the term normal women anymore, but women who weren't affected by hemophilia. And as you can see, much higher rates of bruising in carriers, much higher rates of heavy menstrual bleeding, and really across the board, just more bleeding in folks who were quote unquote carriers. So this can very much be a symptomatic state. Not every carrier will be symptomatic, but I think we're probably under detecting the ones who are. And as I mentioned earlier, this is just kind of a slide that demonstrates the distribution of different amounts of factor 8 activity. I love being a hematologist because 100% is normal, and I just don't have to know much about math to decide whether something's normal or not. So 100% is normal amount of factor 8. So right here. And everybody in yellow are like the wild type. So this is the distribution of factor 8 levels, factor 8 activity levels in folks who are wild type. And then the red are the folks who are carriers. So again, about half of the wild type genes get turned off, about half of the affected genes get turned off. Normal is 100%. You expect the level to be around 50, and sure enough, that's pretty correct. Most carriers have a level between 40 and 60%, but it can go all the way down. Usually to get to zero, we're talking about somebody has Turner syndrome or something else is going on, but there are certainly carriers who have very, very low levels just due to the luck of the draw and skewed expression. So when we are thinking through a diagnostic algorithm for patients who are hemophilia carriers, we distinguish between, we do look at factor level, even though it's not, again, predictive of symptoms. And so anybody less than 40%, we're actually making an increasing push to call a woman or girl with hemophilia. And then we put them in the mild, moderate, or severe category based on the factor level that they have circulating. Even in boys, this doesn't necessarily clearly correlate to bleeding symptomatology, but it's how we have diagnosed it since the beginning of time. So anybody with 0 factor 8 has severe hemophilia. Folks with somewhere between 5% and 40%, we call mild hemophilia. I will tell you in my clinic, if I have somebody who's symptomatic, I'll just label them with hemophilia at below 50%, because again, I think women are undertreated, it's under-recognized, and so I would rather give them any tool that I can to be taken seriously, and sometimes a diagnosis is it. So folks with levels above 40% or 50% in my case, really the distinction is, do they have a bleeding phenotype? Do they have abnormal bleeding? If they have abnormal bleeding, we call them symptomatic carriers. And again, another reminder that factor levels and bleeding symptoms do not correlate. I have a lovely patient in my clinic with a factor level of like 90%, and she bleeds like stink, and she spent her whole life not being believed. She has a son with hemophilia, and she literally cried at her first appointment with me because nobody had ever believed her before and she didn't know what to do about it. I also have another wonderful patient who is a factor 9 carrier, and she has a factor 9 level of 30%. She's never bled a day in her life. She has totally normal periods. She's had babies, no problem. So you don't get stuck too much in the factor levels. I use the factor levels more as a tool to give people that extra layer of like, okay, here's a diagnosis, here's the ICD-10 code, so somebody will take you seriously. So I'm going to talk a little bit in the next slides, kind of an overview of management of heavy menstrual bleeding for the internist or the hematologist. Um, Again, a lot of times I wind up referring these patients to gynecologists because they have more tools in their toolkit. But the basic tools include hormonal therapy, hemostatic agents, procedural interventions, and I always make sure to add iron supplementation here because we forget about that one, and it's super important for quality of life. So hormonal therapies come in a variety of options. Combined therapies are pretty much interchangeable. There's actually only a couple that are technically FDA approved for the treatment of heavy menstrual bleeding, but in our clinic, patients get put on all different kinds of combined hormonal contraceptives, and it helps. It tends to be rather effective. And so, by combined, I just mean something that has estrogen and progestin. That can be the pill, that can be the patch, that can be the ring. There's a variety of ways to administer these. You can tell patients to skip the placebo pack, so they just take them continuously and they don't have any periods at all. That works great for some folks. Some folks will have breakthrough bleeding, and so we say, oh, every 3 months have a period. The world is your oyster when it comes to these agents. They're very flexible and effective. Again, can be used to skip menses, which we love. 91% effective for prevention of pregnancy. I think we all live on the best coast, so I'm going to assume that we all believe in reproductive care of our patients, and we want to make sure that people aren't winding up with unplanned pregnancies that could be life-threatening in some of these folks. So I talk about contraception a lot because of that. So progestin-only therapies, we actually have some really great options here. Every hematologist, I think probably every gynecologist as well, our favorite thing is the Mirena IUD. It's magical. Um, it causes amenorrhea in 40%, sometimes higher, of folks who use it, which is wonderful. It decreases blood loss overall by like 80%. It can increase irregular bleeding, particularly early, and I find it to be very important to counsel patients to expect that. Otherwise, they get it put in and they feel like they're bleeding more because maybe they're bleeding more days out of the month, even though their volume is overall decreased. And I will sometimes give tranexamic acid to these folks to help them through that. So it can be annoying, and it can continue to cause irregular bleeding in some folks. And that can be a deal breaker for some patients. Extremely effective contraception, greater than 99% efficacy. It's approved for contraception, I believe, up to 7 years now. Folks with heavy menstrual bleeding, I always tell them, hey, if it's controlling your periods and it stops working at year 4 or 5, come in and get it swapped out. It doesn't necessarily work as long for HMB as it does for contraception. Um, the progesterone implant, I think people in general don't like as much. If you have a patient who really wants long-acting reversible contraception, again, this is greater than 99% efficacy. You think they would benefit from a reduction in blood loss. This can be effective. So about a 20% amenorrhea rate, lower than with Mirena, but it does decrease blood loss overall. But the irregular bleeding is even more common with this. So if you have a patient that's really going to be a deal breaker for them, it's probably not the agent of choice. But I do have a few patients that it works quite well for. Progesterone only pills, we use this sometimes. So they can be used in different ways. They can be used to treat heavy menstrual bleeding, and that's like agestin, and they could titrate it. Or it can be used sort of in more of a pregnancy preventative fashion, outside of the acute setting, just for kind of long-term management. Doesn't cause amenorrhea, does increase irregular bleeding, lowest efficacy of any of our hormonal contraceptives. You have to take it at the exact same time every day. If you're off by more than an hour, it can be less effective. There is a new agent out there drospirenone, or Slind, which you may know from its fame as being the agent in the birth control that was the Yaz and Yasmin that was associated with all of the VTE. Doesn't seem to be associated with VTE outside of being combined with estrogen, but the data is still new there. But that one's a little bit more reliable. That one seems to be working a little better. So if we have folks who don't want the patch, or they don't want the Marina, they don't want the etonogestrel implant, and they still need some control, that might be a good option. Depo-Provera is actually the most effective, greater than 50% rate of amenorrhea, but people hate the side effect profile. It does decrease blood loss. It also increases irregular bleeding early on. That improves with time. But yeah, it has a lot of side effects that people don't like. It's also very effective for pregnancy prevention. The thing that is, I think, in our toolkits the most as medicine physicians are antifibrinolytics. I love antifibrinolytics. Tranexamic acid is, in my opinion, the best drug ever created. I might be a little biased, but it works really well. And so here's data from a study where they randomized folks with heavy periods. And here you can see on the left hand, the y-axis, we're looking at mean menstrual blood loss. So here they started out quite high, 160, 180 mils per cycle. They put them on tranexamic acid and boom, it dropped down while it remained about the same on placebo. And so we can see somewhere between a 20, 40+% reduction in blood loss. And it's not hormonal. And I get a lot of folks coming into me who are very anxious about hormones for whatever reason, and so this turns out to be a good option for them. And this study down here is really to show that it works kind of regardless of the etiology. So they did it in a study of folks with fibroids. So that's a specific etiology. It's often surgically managed, and they still found so higher is better in these graphs because it's a reduction in blood loss. So still much higher reduction in blood loss with folks on tranexamic acid compared to placebo. And you can see here the overall reduction in blood loss based on how much they bled. And as you can expect, the folks who had the most blood loss to begin with had the most improvement. So very effective drug. I put the little GoodRx thing here because for some reason, insurance companies don't always pay really well, particularly if you have folks who are having periods longer than 5 days. The insurance companies say, oh, the studies only did it for 5 days. Okay, sure, but it didn't need to be done that way. I have patients who take tranexamic acid every day of their life for weird and rare bleeding disorders. So I send folks to GoodRx if their insurance won't cover it, and they've gotten good coverage that way. Procedural therapies, I'm just going to kind of blast through this slide. They are available. Our gynecology teams can do them. Ablation can be very effective. We don't see a lot of uterine artery embolization. That's mostly for fibroids. Hysterectomy is the extreme. We want to avoid that if we can, because obviously there's a lot of morbidity associated with that, but these are options. And as I mentioned before, making sure that we treat iron deficiency. So these are some interesting data on platelet aggregation from one of my colleagues who looked at platelet aggregation in patients before and after getting treated for iron deficiency. And so you had folks coming in who had ferritin less than 50. They did the aggregation, they gave them IV iron, and they looked at the aggregation again afterwards. And you can see a significant improvement in platelet aggregation afterwards. So iron deficiency does seem to have an impact on platelet dysfunction. And so we got to make sure that we're treating patients with iron as well. And so moving on to bleeding disorder specific treatments for heavy menstrual bleeding, there are none. We treat them exactly the same as we do folks without bleeding disorders. Briefly, this is a slide from a clinical trial where they randomized folks with von Willebrand disease to tranexamic acid or recombinant von Willebrand factor because that was who sponsored the study, and there was no meaningful difference. And so if you can give somebody a pill 3 times a day versus them having to infuse themselves 3 times a week or more, the pill is obviously the winner. It's cheaper, it's easier, and so we don't tend to give factor for periods. And so because I did have some of my research in here, I just wanted to acknowledge I have some great funding sources, some great mentors, some great colleagues. And with that, I am happy to take questions. And I'm going to stop sharing so I can see um, all of your faces and the questions as they come in.
Well, thank you so much. That was amazing. I tried to live tweet some of these pearls as we went along. I didn't definitely wasn't able to capture everything, but I got some of the things out there. We have some questions in the chat, and if folks are in the audience and have other questions, feel free to pop them in the chat and upvote or downvote the questions, or upvote, sorry, the questions that are most of interest to you. And I'll just start with the first one, which was, do serotonin reuptake inhibitors make menstrual bleeding worse?
That's a great question. And we don't have a definitive answer to that. So we do know that they do appear to impair platelet function in some individuals to varying degrees. It's certainly not a uniform effect. What I typically tell patients, if they have a bleeding disorder, they want to start on an SSRI or an SNRI. I consider those to be life-saving therapies, so I never say no. I just tell patients like, hey, pay attention to your bleeding symptoms. And if they get worse, let's talk about it. We can implement other treatments for that. They can consider switching agents if they're not getting maximal effect. So I tend to work around that, but they might and they might not. It's hard to say. So serious bleeding is rare with SSRIs, I will say.
Okay, that makes sense. Thank you. There's a question here about stress and other factors and how they relate to heavy menstrual bleeding. So the question is, does high stress, whether psychosocial or physical, such as high performance athletics, play a
Mm.
role in heavy menstrual bleeding? We've heard about these things playing a role in people not having bleeding, but do they also have a role in, or are they associated with people having heavy menstrual bleeding?
That's a really good question. I don't think that we have an answer to that one either. I will say that so this is a specific etiology, fibroids. So the rate of fibroids in Black women is phenomenal. It's like 80% by a certain age. And there's no biological reason for that. So we attribute that to the stress of structural racism, because we don't have another specific pathway. So based on that data, I would say probably stress has some contributor, specifically physical stress like athletes. I don't know. I will say, anovulatory bleeding, so meaning people who aren't regularly ovulating is like the most common cause of heavy periods in younger folks. So if you have high performance athletes who are losing weight, yes, they may be amenorrheic, but then the period when it comes may be really heavy. So I could see a relation there, but I don't think there's been a study specifically looking at rates.
Got it. Thank you. Um, I think this is a doctor who says they work in the Stanford Autonomic Disorders Clinic and routinely check ferritin and iron studies in young women with POTS. And
Mm-hmm.
they find ferritin is abnormal in about 40% of those patients, even when they don't have anemia. And many report their cycles as normal, as you mentioned. But iron supplementation and iron supplementation alleviates their symptoms significantly. So it's really a comment just sharing their experience. I don't know if
Yeah.
you have anything to add to that, but that was just sharing that.
I would say thank you for that work. That's awesome. I love hearing that. It's interesting that you mentioned POTS, because I see a lot of patients with Ehlers-Danlos type pictures and POTS, and there does seem to be some aspect of a bleeding disorder in some patients with Ehlers-Danlos. So I do a lot of evaluating my patients for hypermobility in my clinics, and I've had physical therapists come to clinic with me, and they're like, "Why are all your patients hypermobile?" I'm like, "Well, I think it's a cause of their bleeding disorder." So that's very insightful. Thank you for sharing that.
Yep. Um, and there's another question here that just popped up. Does elevated arterial blood pressure have a relation to heavy menstrual bleeding, or what about vascular malformations?
That's a really good question. So I don't think that there's probably a direct association. When we think about, uterine hemostasis, which I'm going to try to rein myself in because I could talk about that for days. In theory, like we're seeing the ischemia from constriction of those spiral arteries, and we think most of menstrual effluent should just be that shed lining. But in folks with heavy menstrual bleeding, what we think is happening is they're not clotting off those spiral arteries like they're supposed to, and they're continuing to lose actual blood. I don't know of any data that suggests that elevated arterial pressure would affect their ability to clot off those arteries. But I would say general inflammation from metabolic syndrome or whatever else is going on is probably not great for it. Vascular malformation. So there's also some interesting data about increased heavy menstrual bleeding in folks with HHT, hereditary hemorrhagic telangiectasias, which is a vascular malformation disease. They don't tend to have telangiectasias in the uterus as far as we know. They do tend to have more. There's some data that suggests they have a higher rate of heavy menstrual bleeding, which I wonder if that's actually the iron deficiency playing a role there. But that's the only data that I'm aware of linking vascular malformations and heavy periods.
Perfect. Thank you. There's a comment in the chat, but I think so it's not listed as a Q&A, but I think is worth talking about, which is about endometrial cancer. When do you start thinking about endometrial cancer when you have patients with heavy menstrual bleeding? Like do you have a strategy for that?
Yeah, that's a great point. I'm really lucky that I see most of these folks in concert with a gynecologist, so I'm not usually the one making that call. I will say, as a hematologist, if I have somebody who's had heavy menstrual bleeding since menarche and it's continued, that makes me think more bleeding disorder. If I have somebody who's developed heavy menstrual bleeding later in life, again, particularly like they've mentioned, if associated with obesity, that makes me start to think like, okay, you really, really need to get into a gynecologist. You may need an endometrial biopsy. And certainly, risk increases with higher age. So I would think differently about a 40-year-old than I do about a 21-year-old. So those are some things I keep in mind. But I always offer a referral to gynecology because mostly what I can offer as a hematologist is tranexamic acid, which can be effective, but doesn't prevent pregnancy, doesn't consider all these other things. So I refer early and often.
That makes a lot of sense. Thank you. I'm going to go to Dr. Harmon live.
Oh, thanks. That was a wonderful talk. I had a question because you referenced this a few times around sort of how patients are getting referred to you. And I was curious how much you see patients coming to you from like general primary care, pediatrics, um, OBGYN. We have, obviously our department has, and we have a lot of different specialties, and just kind of curious where you're seeing folks kind of getting identified at what stage of their life.
Yeah. That's a great question. So I work in a hemophilia treatment center. So we're a
Yeah,
lifespan center. I have
yeah,
colleagues in pediatrics. And our favorite is when they're seen as kids and they get diagnosed as kids because it helps obviously down the line.
yeah,
But I see plenty of folks. I see, occasionally young 20s. I see a lot of 40s. I see a lot of 50s. There's kind of this myth about menstruation or about menopause, another thing we don't talk about enough, that your periods just like go away, and actually they can get worse before they get better. So I see a lot of folks in that context. Most
yeah,
of my referrals, I get a lot of referrals from other hematologists who don't want to talk about pads and tampons, which is like I'm happy I'm happy to see the patient and have that conversation. I get referrals occasionally from OB-GYN. And actually that mostly comes when they get a referral for heavy menstrual bleeding. They tend to like shuttle those patients into our combined clinic. I wish I saw more patients coming in from their PCPs. I really do. I would say that's the exception and not the rule for how I see patients. And I think ideally we should be talking about periods annually, just like we talk about blood pressure and diet and all of those things. Like it's I don't like calling it a marker of health because then we go down the line of like, oh well, then you need to have a period every month, and that's definitely not true. But it is an important metric and it is a sign. So I would love to see more folks coming from primary care clinics and younger. The younger the better, because we can help them their whole lives then.
thank you.
There's a question in the chat about heavy menstrual bleeding. Obviously, this person says, how well do NSAIDs work? And are there certain conditions that are contraindicated for tranexamic acid therapy, such as previous BTE or CVA or complicated migraines or anything else?
I love this question. This is great. So there are some data that show that NSAIDs do work, and we think it's by some method of reducing prostaglandin, reducing the contraction of the uterus. I don't remember off the top of my head because I'm a bleeding disorders doc, so I don't often go to it. But I think it's probably a similar reduction to tranexamic acid, probably like maybe like a 20% reduction. Works really well for some people, doesn't work well for other people. It's a balance of risks and benefits in patients. If I have a patient with a mild bleeding disorder, their only symptom is really heavy menstrual bleeding, sure, give it a shot. If you have more bruising, let me know. We'll try something else. But it can also help with cramping. So there's like a double benefit there. Tranexamic acid, the only real contraindication to tranexamic acid, as far as I'm concerned, is DIC. I would say an acute VTE is a relative contraindication because we want fibrinolysis to be happening in an acute VTE, right? We want them to be able to reestablish as much blood flow as possible. So I avoid it in the first month, the first 3 months after a VTE if I can, but the data are very clear that tranexamic acid does not cause blood clots. So we've had these meta-analyses, huge studies, postpartum hemorrhage, motor vehicle accident patients, orthopedic surgery patients, like all the highest risk patients, cram all the data together. They're all randomized, no increased signal of VTE compared to placebo. The only one study that ever suggested it was one specifically of GI bleeding, and they had this really unique dosing schema where they actually gave a gram 4 times a day instead of 3 times a day IV, which was not something that we ever actually do in clinical practice. So I feel very comfortable using tranexamic acid in folks. There is also like a relative contraindication with hematuria because you don't want to stabilize a clot in a ureter and get hydronephrosis. So we try to avoid it in that scenario. That said, I use it prior to urological procedures sometimes in patients with bleeding disorders. So you don't hopefully get that bleeding. If the bleeding hasn't started, you can't cause a clot. But yeah, those are really the only scenarios in which I'm worried about TXA. It's great. I'd put it in the water.
Thank you for that thorough answer. There's a question here about I just want to acknowledge we have 3 minutes left and there are multiple excellent questions here. We're probably not going to get to all of them, but we'll keep on trucking for a few more minutes. How often in women with heavy menstrual bleeding and iron deficiency anemia do you recommend a workup for GI blood loss? Or do you do that at a certain age, or what other thoughts do you have around that?
That's a great question. So the standard is if they're over 35 and they have anemia, they need to be referred. I think, the data around people with iron deficiency without anemia is new because we haven't been detecting it. I had a patient just earlier this week. She has pretty heavy periods. I gave her a dose of Infed, which is a gram of IV iron. 3 months later, she was iron deficient again. She's getting sent for a GI workup. Like, that's too much. If the periods are staying the same and you're not getting a benefit, then I send folks for a GI workup. But anybody over 35 with anemia should definitely be going.
Thank you. That's very helpful. Back to tranexamic acid, there's hopefully a quick question about whether it is associated with increased risk of endometrial cancer.
No.
Great.
Not to my knowledge. Look, I gave a short answer.
That's perfect. There's a question, a little bit of change of path here about training. And this is a question from one of our hematologists, Dr. Beth Martin, who says, can you comment on the impact of the rarity of hematology fellows choosing classical heme and the need to provide additional education to primary care and OB?
Oh man, that's another one I could talk for a long time about. I think yes. So the rarity of people going into classical heme is an issue, particularly since a lot of the folks who trained me are retiring now. I think, you really have to want to stay in academics to do classical heme. It's not like really a primary care specialty. But I think a lot of people just don't understand how much benefit, like in my clinic, like I have a clinic right after this, and I guarantee you one of my patients will say, my life is so much better because my periods are reduced. Like, we get that we make impact on quality of life. We're not saving people from cancer. Sometimes we are. Sometimes we're catching the cancer and getting it diagnosed. But I think people just don't appreciate what a rewarding specialty it can be. And so I would really love to see see residency training programs making more effort to put people into clinics, and classical hematology clinics instead of just like the leukemia service, which was not my calling. Let's just put it that way. Yeah, and I think, pulling in, I would say I work most closely with gynecologists more than hematologists. And so I think having them involved, super important. We have really good research collaborations in our group. I would love to have more interaction with internal medicine folks, with primary care physicians. I think giving folks those opportunities in training to come and shadow, I think would be really beneficial, but it's a big problem.
Yep. Yep. Thank you. And the last part of that question, I think, was about suggestions for how to educate folks in primary care and OB about classical heme.
Yeah. Oh, about classical heme. That's a great question. I mean, I do a lot of lectures like this talking about heavy menstrual bleeding, and maybe this is a great suggestion. I should do more of a like come to the happy side of classical heme. But I think, yeah, getting people exposed to the idea that it is a specialty and it is a fun specialty, especially now that we've called it classical heme. It sounds like we're like reading Homer in the corner or something. It's way more fun than that. I mean, Homer's fine, but I think it's way more fun. So I think people just don't know, right? We're like the best kept secret. And I remember going on my hematology interviews and meeting with people, and I'm like, oh, these are the first people in my life who understand my sense of humor. Like, we're kind of a weird, fun little bunch. So the more we talk about it, the more people will hear about it. I think that's all we can do.
Awesome. Thank you. Okay. Is that 9:01? Do you have time for one more quick question? I think it'll be quick.
Sure. Sure.
Okay. This will be the last question. And it's, by the way, all these comments have been preceded by excellent talk, amazing talk, awesome talk. I've just been leaving those out for brevity, but this person says, awesome presentation. Do you use gene therapy like, and I apologize if I get this pronounced wrong, hemogenics, for women with hemophilia or carriers with heavy menstrual bleeding?
Great question. So there have been no studies, no women have been included in the studies of gene therapy for hemophilia. And it's really because they've restricted it to folks who have severe hemophilia and women generally don't. And also because we have weird ideas about whether or not women can provide informed consent for fetuses. But yeah, that has not been studied yet. Most of the products so far only buy people at baseline, like maybe like a 20% increase. So if you have a woman with like 40%, we don't know that 20% would, a 20% increase would be meaningful in anybody, particularly not in women where the levels and the symptoms don't correlate well. I think probably our symptomatic carriers probably have other things going on that we are not able to detect, like connective tissue disorders and things like that that are contributing, that may be playing more of a role than them being carriers, and it's just additive. But women have not been included in those studies yet. It's a bummer.
Yeah. Wow. That's, I mean, you would think by now, given the mandate, especially from NIH, that would be happening. But
That's
well,
not
thank
being
you.
passed on to the study sections. It's not. Yeah.
Okay. Well, seems like it should be.
Yeah, I agree.
And on that note, thank you all for staying. It's 9:03, so we're past our time here. Thank you, Dr. Samuelson, Bannow, for such an engaging talk and answering all these questions very rapid fire. We really appreciate the work that you're doing, and we'll call it there. I hope everyone has a lovely day. Thank you for joining us.
Thank you. My pleasure. Thanks for having me.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.